Lovely seeing everybody saying hi in the chat from where you're at. So feel free to keep doing that. It's cool to see from so many places around the country. I haven't seen any international yet. So if you're calling in from outside of the country, feel free to drop it in there. It'd be cool to see who's coming in from all over the world. But yeah, as David mentioned, my name's Niko. I'm one of the co-founders and president of the company. I'm having a very relaxed week, not being at HIMSS this week and sitting on my couch at home in my Redox Red Sox t-shirt. So very happy to be hanging out with you guys. So what I'm going to do today is kind of talk through the state of interoperability as we see it, kind of as it is these days right now. And to give some context, I always like to bring in who we're here representing. So this is the Redox team, our latest team picture. We're nearing 200 people now, which is wild. And one of the things that we always kind of start every meeting with is kind of grounding ourselves in the fact that we're all patients. It's hard when we're in this interoperability space to realize every single day the impact that we have on patient care. So bringing that saying into our meetings and into what we do is really important to making sure that we understand why it is that we do the work that we do. And remembering that healthcare happens at this intersection between patients and providers. And it's really at this intersection that the sort of sacred moments in healthcare happen when a provider can actually look into a patient's eyes and understand that there's something going on there beyond, what they might be saying in what their labs might be saying or what it might have within their chart. Technology at its core should really support that empathetic interaction between patients and providers. And in doing so, technology should make providers more efficient at delivering the care that they need. And that should enable providers to deliver better healthcare with higher quality. And it should also enable patients to be empowered and engaged in their healthcare. This is core to the application layer that interoperability and technology can create, that we can turn that data into these pieces of technology that create these efficiency gains and create this empowerment for patients. But it's so often in healthcare that the reality of the situation is that technology that has been introduced actually creates inefficiencies for healthcare providers. And that inefficiencies contribute to the commoditized relationships that we're starting to see now with the patient-provider interactions, and that contributes to provider burnout and a lot of the challenges that we see in our healthcare system today. It also generates a level of fear at worst, or apathy at best, with patients interacting with our healthcare system. So technology has really not enabled a better healthcare environment that was really hypothesized. And there's some underlying factors around that. So of course, any talk about healthcare talks about how much the US spends. So I'm an economist by background, and so I like to always bring the data into it. We're approaching 20% of GDP being spent on healthcare, nearly $10,000 a person, which is more than double the average of OECD countries. And a large part of that, there was this great study in 2012 that looked at where our excess spending was coming from. And this pie chart here kind of breaks down where the excess spending is. But the study looked at how much we spend and estimated that about 1/3 of healthcare spending is actually waste. And the thing I love about this pie chart is that each one of these slices is what we see entrepreneurs targeting as their, as ways that technology can actually bring efficiency gains and cut down on unnecessary services or excessive administrative costs or prices that are way too high in our system or inefficiently delivered care. So as entrepreneurs looking at this problem, we see a lot of people focusing on these different areas. At its core, though, technology is something that people use to make themselves more efficient. That's kind of in the definition of technology. And so we obsess over this challenge of how do we make technology adoption more seamless in the space. Technology adoption didn't come easy to healthcare. The way that we saw electronic health records cross the technology adoption chasm was really on the backs of a subsidy. Meaningful use was introduced in 2008, more than a decade ago now. And it really caused EHRs to cross that chasm. Typically in in the crossing the chasm sort of literature, they talk about what's necessary for technology to go from the early innovators, early adopters into the early majority and kind of the mainstream of adoption of any technology. And what that typically requires is a 10x improvement over the status quo. And electronic health records back in 2008 were really in this innovator bucket, in this early adopter bucket. And instead of having a 10x improvement on their technology, the government put forth billions of dollars in subsidies to hospitals and to eligible providers to adopt electronic health records, and pulled them across the chasm to where we are today with near ubiquitous adoption of the technology. So what we missed in that 10x improvement were advances that would have probably created electronic health records that were built in the cloud, so something much more scalable than the on-premise infrastructure that we see today. They probably also would have improved the user experience. So you can't find a provider who likes their electronic health record. That was probably missing in that 10x improvement that could have happened without the subsidy. And we probably would have seen electronic health records become more interoperable. So these are all hypotheses of a counterfactual that we'll never be able to see. Additionally, we probably wouldn't have seen the near ubiquitous adoption of electronic health records without the subsidy as well. So from a policy perspective, I'm not sure how we could have changed that, especially given the economic circumstances of 2008. But just kind of pointing out that electronic health records didn't go through the typical technology evolution that causes ubiquitous adoption. They were really adopted based on the subsidy of meaningful use. Nick's going to talk about a little bit later in the program around how the government has built on the meaningful use program with some of the new regulations that ONC and CMS put out yesterday. So we'll dive into more about how the regulatory landscape is changing around this, but something to keep in mind that set us up for where we are today from an interoperability standpoint. What that led to is we have electronic health records, but we need more technology in order to hit some of those opportunities for efficiency gain that I talked about earlier. And the American Hospital Association a couple of years ago put out this great study where they actually surveyed health system leadership and IT leadership, and came out with some really great stats showing that there's this big gap in what health systems want to utilize, technology that they want, and technology that they actually end up putting in place. So some of the big ones to pull out here is that 75% of health system leadership believe that digital innovation is essential to meeting their long-term goals. But it takes on average of 23 months from identifying that a solution is needed to actually implementing that solution. So this is that sales cycle that so many entrepreneurs deal with and have left so many dead companies in their wake. It takes 2 years from the healthcare organization realizing that they need something to actually adopting it. And that is way too long from a technology standpoint. And 54% believe that time they put into digital innovation is spent inefficiently. So there's a lot of improvements that can be had here. At its core, what we believe is that technology lacks an healthcare lacks an interoperable infrastructure. It's really this technology down here below the line that is that doesn't, it's the infrastructure that isn't directly interacting with providers and with patients, but supporting technology that does that. So of course, there's a lot of players in the space attempting to provide that technology infrastructure to make that to make this dream a reality. So I'm going to go into here how we can actually create this more ideal situation where we have that infrastructure and provide efficiency, provide empowerment for a better healthcare for all. So I want to do a landscape map of what the interoperability landscape looks like. Interoperability, beyond being a very large word, is loaded with all sorts of different vendors and players and really definitions that make up what interoperability is. So let's dive in here. So I'm going to overuse my Venn diagram to kind of describe various types of interoperability and the players that you'll run into in the space. So probably the most traditional definition of interoperability has to do with a patient moving from one care setting to another. So a patient going from a provider setting into a hospital setting, or to a specialist, or to an outpatient surgical center, or to a skilled nursing facility, or all the different care settings you might imagine. And I kind of bucket this as transitions of care. So these are data sharing networks, HIEs, or the hip new thing that they're saying is HINs, health information networks. And the new HSS ruling really says those things are the same, but essentially these are different platforms that allow data to follow a patient from different care settings. And so you have protocols like direct trust that allow messaging to happen between various providers. You have Commonwealth or Care Equality, which are networks of healthcare providers that you can utilize to query for various information. You have private companies like PatientPing, who's doing a great job notifying within a given region if a patient has moved from one care setting to another. And then you have kind of underlying software like Medicity or HealthShare from InterSystems that is a lot of the technology that HIEs will utilize, or some of these HINs will utilize to actually gather information from various care providers, standardize them, and make them available to share with each other. So that's kind of the landscape of transitions of care. And it's really all about how data moves between one care setting to another. This isn't something as a software developer that you would necessarily plug into to utilize those networks. They're really about various care providers and, for the most part, electronic health records exchanging data with each other through the means of these technologies. The next area is a bucket of technology utilized by healthcare organizations, hospitals, and practices to drive this kind of efficiency bucket of care. And there's a few different subcategories in here. The first one is interface engines. So things like Ensemble or Cloverleaf from Infor, CorePoint, and Orion with Rhapsody actually merged with CorePoint, so now they're the same company here. But a lot of the common interface engines that are used at health systems, these are on-premise pieces of technology that are designed to integrate pieces of software that is used within that healthcare organization. So it's not really designed to send data outside of the four walls of that healthcare organization, but really for other pieces of software used, like their practice management system or their internal lab system, things like that. Another category here are the actual vendor-specific API programs. So EHR vendors will have their own APIs that will allow applications to hook into them and really kind of bypass the interface engines and utilize APIs. So there's a whole set of vendor-specific programs. The first one was probably the more disruption please program from Athena Health. And then I think Allscripts, their ADP program, came in. Eventually, we had Cerner and Epic join the mix with Code and App Orchard, respectively. But these are programs where applications can apply to be a part of them, utilize the specific APIs that those EHR vendors make available, and then integrate with those EHR's customers, these hospitals and provider groups. Additionally, we're seeing providers adopt API management tools, things like MuleSoft or Apigee, where they stand up an API layer specific to that health system and make that API available to any applications that might want to use it. So it's great for the health system to be able to have an API layer that they can build and manage. But one of the challenges that we're seeing is that they're very different across various health systems. And so, they have APIs, which is a great step in the right direction, but the consistency of those APIs is kind of a challenge in some cases. So moving on the patient side, there are patient-facing platforms that allow applications that are consumer direct-to-consumer or consumer-facing tools to be enabled. So a couple of the ones that are kind of most closely directly associated with that are groups like OneUp Health or Human API, or even you might even say Apple Health Kit is doing this, where they're being the infrastructure that sucks patient data out of the health systems and gives an API to developers to build applications on top of. Validic is another company kind of in this bucket, although instead of the actual EMR data. They're looking at more of the wearable space, or any devices. So beyond wearables, things like smart scales and glucometers and other sorts of consumer devices that have some sort of data that needs to be made available in an interoperable way. And then we have companies like Xealth or RX Health that are implementing with health systems such that a provider can prescribe an application to a patient. Because as we know, patients are much more likely to use an application if providers are telling them to. So those are great pieces of software that we're seeing provider organizations adopt so that they can more effectively distribute applications to patients. So yeah, that's kind of a quick overview of the landscape here. And to throw it all in one of these feature tables, where of course Redox checks all the boxes, we can kind of see some of the differences between them. So let me just run through this pretty quickly. So with interface engines, they do build a network, but it's within an instance of that interface engine at a health system. So it makes a little mini network within a large healthcare organization, and they do offer read-write capability within EHRs. It's bidirectional, but often health systems have to manage that on their own, so they have their own interface teams. These aren't traditionally supporting modern APIs, so they are. It's HL7 primarily, sometimes CCDs, and they're not really customizing any of the data, or standardizing, I should say, any of the data within, between healthcare organizations. Sure, it's HL7, but as anyone who's worked with HL7 knows, it varies dramatically between different EHRs and different healthcare organizations. So those API management platforms, the next category going down here, they do offer modern APIs. And they can offer read-write capabilities depending on how they're built within a health system. But again, we have different kind of data types, different data standards that are used across different organizations. It does not build a network, so it offers an API for that health system, but not networked across many health systems. And often health systems have to hire, their MuleSoft expert or, API builders to build and manage those within their organizations. EHR marketplaces are an interesting category here. So they do standardize data for their own customers. Although, the syntax might be the same, but the contents of the data messages might vary based on what the actual, hospital or provider customizes within their EHR. A lot of them are offering modern APIs and read-write access. So, those are great features within those EHR marketplaces. HIEs, they basically have to standardize data across organizations. So that's a great feature from an HIE perspective. But of course, they're using CCDs primarily, or ADT, HL7 messages, and across their network. Their networks are kind of also regionalized for most HIEs. So that's, you might have a network that works within a given region, but kind of a national network is something that might be missing, which is where kind of HINs come in, the new categorization from HSS, where like things like Commonwealth and Care Quality, they have a networked approach that's much larger and more nationwide. Patient authorized vendors, we are seeing the data sets become more standardized. So, and Nick will go into this later in his presentation, but USCDI has been adopted as the applicable data, at least for the next 2 years, that we'll see available via patient auth. We're seeing modern APIs become more widely available, and that's FHIR R4 has been chosen as the standard for that API. But some of the things lacking here is that we don't have a networked approach. And that's where things like Apple Health Kit or OneUp Health or Human API are trying to create a network of all of the disparate patient authorized endpoints here. Right now, it's also only read-only, so we can't actually write back into the EHR with patient authorized APIs. So some of the challenges there. So I want to talk about kind of scalable interoperability for software vendors. So this is a slice of the interoperability landscape. But if you're a software developer who is building some sort of product that you want to get in the hands of patients or providers, how can we do that in a scalable way? So to start off with, the ecosystem that we're talking about here, you might be one of these applications at the top creating a great coordination app, and this one looks like it might be a what could that be, some sort of yoga app or something, I don't know, that takes a lot of coordination. And the challenge is, how do you get this integrated with all the different health systems on the bottom? So if we put ourselves in this kind of coordination application, in their shoes, they're dealing with that 2-year sales cycle with all of the different healthcare organizations that they're trying to sell to. And once they actually make that sale at a health system miraculously, then they have to go through IT. They have to set up typically a VPN. They have to process the HL7, get through the security check, the security checklist, the data governance committee, all of that. And finally, after 2 years, they get live at their first healthcare organization. And this introduces one of the first market failures that I talk about in the ecosystem, and that's the health tech cost spiral. 2 years of a sales cycle, as well as what it takes to maintain momentum over those 2 years, is wildly costly for any software developer or software vendor to go through. And therefore, they have to charge a price that's high enough to warrant a 2-year sales cycle. So it's very rare in healthcare to find software for under 6 figures because of this challenge. Like, it doesn't make sense to sell software for very cheap because you have to warrant a 2-year sales cycle. So prices are high. Because prices are high, it takes longer to sell with health systems because they have to go through budgeting and figure out where to get the money. And so if it takes longer, they have to raise the prices more. And so we have this cost spiral that creates one of the big challenges in creating technology and software that is much more easily adopted by health systems. The cost it takes to create an application in healthcare isn't much more than a lot of the free apps that we get in the App Store, but the barriers to entry are so high such that that healthcare software has to be really expensive. So let's say you finally got your app live at this first health system and work through that sales cycle. Now you have to get from 1 to 2 to 3 to 4, and so selling to each and every one of these healthcare organizations requires you to scale your sales team to maintain momentum working with each of these organizations. It requires you to scale your integration team, because each one of these health systems will have their own ways of integrating. And this brings up another challenge, another market failure in the healthcare technology space that I call the myth of scale, which most software vendors in the modern world with cloud technologies, with the way that software is deployed these days, can scale their users without scaling their own infrastructure costs and software development costs and sort of costs to the organization. So you can have, in the consumer app world, for instance, you can have an app that has scaled to hundreds of millions of users and still have a relatively small organization supporting that application because of the way cloud technology has been proliferated across the industry. With healthcare technology, because of the cost that it takes to literally integrate with all these groups, we've been seeing teams of engineers with these organizations kind of scale at a linear rate. You get a new customer, you have to add more people to support that customer, and so forth, because of the customization that happens at each level. Because of that increases the cost of providing the software, and then of course that contributes to the cost spiral that we talked about previously. So another one of the challenges here. And then if we take a step back and look across the entire industry of various software vendors in the market, we have this web of redundancy where each vendor has to be maintaining these integrations and maintaining their relationships and momentum with sales cycles across the entire ecosystem. And what that does is it creates this huge web of redundancy that is massive inefficiency when we think about technology scaling in the space. So this is the challenge that Redox really set out to solve. So we're not looking at how data moves directly between each care setting. We're really looking at this holistic problem of technology adoption in the industry and how it can be made more efficient through the use of a platform. And that's where Redox likes to set ourselves up. So being the shared network where we integrate with various health systems and offer a clean API for developers to plug into once and have a shared network that you can integrate with any health system with. So that was the idea behind Redox. We've been doing it like 6 years now. It took us about a year to figure out which side of this was our customers. Do we serve the developers or do we serve the health systems? And I think what became very clear, as we ourselves tried to go through that long sales cycle with health systems, is that that wasn't going to be sustainable for us to actually grow our network fast enough on. So we made sure to focus on making sure developers' lives were easy, such that they would bring us into the health systems that they work with. So our APIs, our customers, our constituents are the developers making these applications. And yeah, we deal with health systems, we deal with their IT teams, but we do it on behalf of the developers that are building applications on top of the network. That's our primary kind of path to market, and how we've been able to grow the network over the years. The network today, on one side we have the health organizations we plug into, and on the other side we have these applications. So you might notice some of the logos here, but really what I would say, the top healthcare organizations in the country we're plugged into, and we're exchanging data with the top digital health companies and device companies and other sorts of applications. When we break it down, that's about 700 healthcare organizations, provider groups that we're connecting up to right now, and about 275 vendors. Across these provider organizations, we're integrating with many, many different types of EHRs. I think the number's like 40 or 50, something like that, different EHR vendors that we're plugged into across all of those organizations. And basically, when one of these vendors comes to us and needs to integrate with a health system that's not on the network, we don't charge to bring that health system on the network. It counts kind of as the same as any healthcare organization. And if it's a new EHR, we'll plug into it because that's what's necessary to bring that healthcare organization onto the network. So that's kind of a quick overview. Holy cow, I can't believe I made it in the time. Sorry for talking so quickly, but find me on Twitter. We'll address the questions below kind of in text as we move on to our next presentation of the day.